So hello, everyone. Um, Today, I will be giving the presentation Early Echocardiographic Predictors of Bronchopulmonary Dysplasia Associated Pulmonary Hypertension. And this presentation is made in the context of the 16th UCSF International Conference for Neonatal and Childhood Pulmonary Vascular Disease. I really want to thank the organizing committee for allowing me to speak at this really wonderful conference. So in terms of disclosure, Medtronic, via competitive research grant, provided NIRS monitors and sensors for a study that is currently undergoing at the Montreal Children's Hospital. The objectives of this talk today is that at the end of this presentation, participants will be able to review some of the current knowledge pertaining to the association between early echo findings and the later diagnosis of BPD-associated pulmonary hypertension. We'll evaluate some of the potential future investigational avenues regarding the prevention of bronchopulmonary dysplasia, pulmonary hypertension, and we'll briefly discuss some of the LV phenotype in the context of prematurity. So as many of you know, we are currently, as per the guidelines, recommended to perform screening with echocardiography at 36 weeks post-menstrual age in infants with prematurity and with bronchopulmonary dysplasia that's already established. But the question is, by the time of screening, are we actually a bit too late? And once the actual phenotype of pulmonary hypertension is established, well, could we have prevented that? And could we have acted earlier to avoid getting to the point of this pulmonary vascular disease? And so sometimes you reach 36 weeks, and this is an apical four-chamber view with a very enlarged right ventricle and a very squished or pancake left ventricle, probably because of decreased preload, but also because of shared fibers. This RV is with severe dysfunction. And we're there at 36 weeks, and one may wonder, well, is this too late? And could we have prevented the fact that there's already end organ involvement at the level of the cardiac function? And so we know, especially, that the phenotype of cardiovascular disease related to prematurity is probably a condition that spans across the lifespan. And as such, we know that there's elements that starts, yes, in the fetal life and continues into the neonatal life. But all of these elements are potential modifiers, but also potential insults that will continue to go on and added layers throughout the life of these patients, potentially impacting their development, their cardiorespiratory reserve, and their capacity to actually grow healthy. So we want to try to avoid having a phenotype like this as soon as possible. So this is just an example of one patient with prematurity that we've seen in one of our studies, a prospective study looking at natural history of patients with bronchopulmonary dysplasia and with prematurity. And already at the time of diagnosis and pickup, we have suprasystemic pulmonary hypertension and signs of RV and LV involvement. So infants with prematurity and bronchopulmonary dysplasia, as we all know, have immature lungs that's subjected to reactive oxygen species, volute, barotrauma. They have immature and abnormal repair mechanisms, as well as fibrosis that takes place. They get inflammation injury from exposure to chorioamnionitis, eventually infections, neck, subchronic infection, but also from iatrogenism from the mechanical ventilation. They have disturbed growth and suboptimal nutrition, despite all of our attempt to do provide good nutrition. And some of them will be exposed to some interventions, example, postnatal steroids, which may also alter vascular growth, but help with inflammation. And on top of it, there's the complexity of genetic predisposition and the fetal environment, such as a placental vascular dysfunction and growth restriction, which can also alter the overall phenotype of these patients. Now, typically the pulmonary vasculature follow hands in hands to bronchopulmonary dysplasia. And as we all saw yesterday throughout the actual fetal neonatal growth of the lungs, these vessels will track how the parenchyma will grow. So at any point where you get disruption of that, you can assume that there might be a component of pulmonary vascular disruption. And we know that patients with BPD will have abnormal vascular pruning and remodeling, muscularization of the vasculature of both the arteries and veins, abnormal response to some of the substances that are regulating vascular tone, which seems to be very heterogeneous as well, the same way that BPD is very heterogeneous. We have often VQ mismatch, airway disease, aspiration, CO2 retention. We often have increased pulmonary vascular tone, decreased vascular territory, as well as abnormal venous drainage. But typically, one thing that is on our side is that once the lungs are getting better, often the vessels also do get better, although sometimes you do get a disconnect. So this is one of the first projects I was interested in, is to look at the population of patients with bronchopulmonary dysplasia, and that was in a population prior to the era of screening. So this is a population of 61 infants who were actually referred to our pulmonary hypertension service at Stanford, and who had already signs of pulmonary hypertension, either because they had symptoms or eventually they were referred from an outside center. And as you can see from these patients who probably presented with a more severe picture just because they were detected clinically, they were within the range of extreme prematurity. And at a follow-up of about 5 years, a third of this cohort had already passed away. And what was clear is that the age at the diagnosis of pulmonary hypertension and the severity of the lung disease were the two elements that were increasing the risk of death. And so I think for me, it makes a lot of sense that we're screening and that we're attempting to screen earlier, because I had just mentioned the age of diagnosis may be a contributor to how we're able to manage these patients. And in those survivors, at least a third of them still had persistent PH, with many remaining on some medications. And 16 of these infants developed pulmonary vein stenosis at a median age of 56 weeks of postmenstrual age, which, as you can find, is a relatively late finding compared to the pickup of pulmonary hypertension. So then we went and looked back at this cohort of patients, and we looked at their first echo at the referral at our center. And what we found was, not surprisingly, that the right ventricular function already at arrival within the referral context was predictive of mortality, as well as the degree of pulmonary hypertension severity. And, RV function here was measured by tricuspid annular plane systolic excursion, fractional area change, and strain. And these patients, they died because of their cardiac and respiratory failure condition. So when I joined back the Montreal Children, we had already established our protocol in 2015 for screening of pulmonary hypertension in patients that are born premature. And so we had at our cohort 222 infants born less than 29 weeks, out of which 144 were free of PH. So we're still talking about a third of our cohort showcasing signs of pulmonary hypertension on their screening echo. And out of these 78 infants with pulmonary hypertension, we had only 6 that had a mortality outcome post-diagnosis, which is less than what the literature has established once you have a diagnosis of pulmonary hypertension. And I think part of the reason might be that we picked up milder cases in the context of screening, but also by being aware of the condition, there is a certain degree of education, awareness, and potentially more sustained management of these patients, knowing that they're particularly vulnerable and fragile, and vulnerable to especially viral infections, and to flare-ups of their RV dysfunction in the context of acute pulmonary hypertension crisis. We still had 24 infants, or 11% of our cohort, who presented more than 2/3 systemic pulmonary pressures. What came out of it is that in terms of the demographics, as it was already described, being small for gestational age, the duration of ventilation and the BPD severity was associated with being more at risk of severe pulmonary hypertension. So these were their echo measurements that were evaluated at around 37 weeks corrected age for the postmenstrual age. Here we have those with any degree of pulmonary hypertension versus those with significant, which is classified at more than 2/3 pulmonary hypertension and compared to systemic. And what you can see is that, already at also the screening echo, these patients with some degree of pulmonary hypertension, as well as some degree of significant pulmonary hypertension, had already signs of altered RV function with TAPSE and FAC that was, different than the cohort with no significant pulmonary hypertension. So this is TAPSE, which is the measurement of the longitudinal movement of the tricuspid valve into the right ventricular cavity in systole. It's a marker of RV function. We also looked at their deformational analysis, which looks at pixels of the image and tracks the myocardium in order to provide a percentage of shortening during the contraction. And what we saw was that the left ventricular and right ventricular deformational properties were associated to any pulmonary hypertension, as well as being more than two-thirds systemic. And that's a screening echo. So for me, what was striking is that already at 36, 37 weeks, during screening, once you already had signs of pulmonary vascular disease, these patients seem to have early signs of RV and LV alterations. And so this seems like there might be some degree of complex phenotype of biventricular involvement, which could either be the consequence or the source of the disease. So we know the RV could be struggling, which eventually leads to the LV struggling. But it does make sense that, the biventricular function may be altered because, the prematurity, and so there's extrauterine growth, there's inflammation that may affect both ventricles. There's steal effect from the coronary arteries, nutrition that might be abnormal, steroids exposure, prenatal factors, oxygen. There's so many insults that may happen that can also alter myocardial health, which makes sense that these patients who have abnormal pulmonary vasculature may already showcase signs that we can detect of biventricular alterations. So again, my question is, screening is important to detect a condition that is relatively silent. But here, are we already too late? And if there are early alterations in cardiac function, which eventually may worsen across the lifespan, could we potentially detect it earlier and act upon so that we're able to avoid or revert this phenotype? And so the question is, first of all, should we screen earlier? And even if we screen, what would we do with it? And, I think the first step as a scientific community, we ask ourselves is there a profile we could target in future trials to prevent the cardiac remodeling? And so many of you know from the group of Colorado, from Dr. Abman, Dr. Morani, this pioneering paper, which was a prospective study in the years 2006 to 2012, which was done in Denver and Indiana. It was infants born at less than 34 weeks with a birth weight less than 1.2 kilos. And they done an echo at 7 days of postnatal life, as well as 36 weeks postmenstrual age. They defined pulmonary hypertension by echo as an RV systolic pressure estimated above 40, or a systolic pulmonary pressure to systemic blood pressure more than 50%, any shunts that were bidirectional right to left, or the presence of septal flattening. As you know, septal flattening at the peak of systole, is an indicator of increased RV pressure overload. And as you can see from this spectrum, is that as you increase the RV afterload, you increase the septal flattening, eventually bowing of the septum, and potentially pancaking of the LV. And so by cath, one study from actually the UCSF group demonstrated that is at least half systemic when you get some degree of flattening, and previous studies had shown that it was at least 2/3 systemic. But we can all see that, quantifying the degree of septal flattening or describing it might be a bit subjective. So this study ended up enrolling 316 infants with 277 surviving to 36 weeks. They had signs of early pulmonary hypertension on 115 patients. and out of them, 21% developed late pulmonary hypertension. They also had 163 infants with no signs of early pulmonary hypertension, out of which only 9% developed late pulmonary hypertension, so about half of the other group. And what was predictive in terms of relative risk is signs of septal flattening on day of life 7, as well as sinus right ventricular dilatation on day 7 of life. But the questions are always, are these findings generalizable? And so you can think of, for example, the effect of high altitude in Denver, the fact that 81% of that population is Caucasian, that the median gestational age might be more closer to 27 weeks when now we care for babies at 22, 23 weeks, that 60% of their cohort was discharged on oxygen, which may not reflect the practice everywhere. And only 7% of the population had a TR-jet present, with only 2 patients meeting the criteria of pulmonary hypertension using an estimated RV systolic pressure by echo. So we look back at our own cohort of infants that were screened between 2015 and 2019. And out of these patients that were less than 29 weeks, we had 176 infants who had an echo in the first 3 weeks of life. Out of these patients, we had 59 that ended up developing either mortality or a BPD-related pulmonary hypertension. We use the first 3 weeks for the postnatal transition as our definition of early echo. And as I mentioned, the majority ended up with good outcomes. So 117 who were free of PH and who survived, but still a third of that cohort who developed a pulmonary hypertension or had an outcome of mortality. We define pulmonary hypertension using the systolic pulmonary arterial pressure above 40, or if that was not quantified, we actually used the eccentricity index above 1.3 at the peak of systole as a marker of septal flattening, which is quantifiable. The eccentricity index is the ratio of the diameter between the parallel measurement divided by the perpendicular measurement, such as perfect circle gives you 0. And as this measurement decreases and this one increases, you get closer to 1.3. We also did what we call the RV to LV ratio as a marker of RV dilatation, where typically you're supposed to have a bigger LV than RV at the peak of systole. And as you're dilating your RV, having a ratio above 1 is an indicator that there might be some degree of RV dilatation. But I think, no one needs an eccentricity index to see that this RV is suprasystemic, pressure overloaded, and pancaking the LV. But this marker allows you to quantify septal distortion. It was actually studied by the group of Abraham and al. In a preterm population and showed high inter-observer agreement with some degree of RV systolic dysfunction impaired within this population once the eccentricity index was 1.3. So that's why we chose this definition. Septal flattening was, described at 1.1, but we use 1.3 as a marker because of this study. And that's been a marker that's been used quite commonly in the literature. So out of our results, what we found was that the average gestational age at birth was around median of 26 weeks. Again, being small for gestational age was associated with, death or BPD-related pulmonary hypertension. We found on the echo, so these are the results of these patients' echo in the first 3 weeks of life. What we found is that the patients who developed death or BPD-related pulmonary hypertension had absolute values of the eccentricity index, which were increased already on their first scan, so 1.35 compared to 1.26. They had more eccentricity index above 1.3, so 55% compared to 34%. We did look at having a flatter born septum. It was more frequent. And the ratio of the RV to the LV diameter as a marker of RV dilatation was also higher in this population. In our cohort, we were able to quantify systolic pulmonary arterial pressure in 100 O2 of the patient population, which gives you 58% of the cohort, and only 22 patients ended up on home oxygen, so 13%. We then did a logistic regression analysis, and we found again that the LV eccentricity index and that the ratio of the RV to the LV diameter was also associated with the outcome of death or BPD-related PH. When looking also at the subgroup that survived, so the 40 patients that survived with BPD-PH, we still found that these patients on the early echo had higher systolic pulmonary arterial pressure, they had higher eccentricity index, and they have more frequently eccentricity index above 1.3, as well as higher RV to LV diameter ratio as a marker of ventricular dilatation in this cohort. So is our data concordant? It is with the study by Mourani et al. So we found that early septal motion was associated with later BPD pulmonary hypertension, that the degree of RV dilatation was also associated. And this is true in a population that's at a low altitude and that is born less than 29 weeks of gestational age, even if there's a context of low rate of home oxygen and with a higher TR-jet present in this cohort. So although the data on ethnicity is not available, the population of Montreal, especially at the MCH, is very highly diverse, which in general, 50% of our cohorts are non-Caucasian. So I looked back and looked at the international level. This study is from Korea and included infants between 22 and 27 weeks. They defined their early echo at 4 to 7 days, and their cohort was managed regarding the PD with a non-interventional approach, which is the same as the Montreal Children's Hospital. So I just want to mention that as a disclaimer. And they defined similarly the definition of pulmonary hypertension. Their outcome was death or BPD-PH. And what they found was that they had 74 infants of their cohort, or 30%, who had sign of early PH, who eventually developed the outcome. So 21 died, 28%. 14 of them developed BPD-PH eventually, and 35 of them developed death or BPD-PH. And when comparing these 74 patients to those with no early PH, they found that those with no early PH, only 15%. So we're still talking about a ratio of 1 to 3. So clearly having signs of early PH is also confirmed at the international level and even on earlier echoes than the one that we just described in the Mourani paper and in our cohort. So having early PH gave you an odds ratio of 6.6 for the outcome of death or BPD-related PH. And so the group of Korea also did meta-analysis, and what they found is that they found 4 studies with early PH within 2 weeks that had an increased likelihood of developing late pulmonary hypertension, and they calculated an odds ratio of around 2.9. And so their definition here of the late PH was being more than 4 weeks of age. But the questions again is, are these findings generalizable? And up to now, beside the Mourani study, our unit, the one for Korea, have a strict conservative PDA policy driving the findings possibly. So I went back and looked at other cohorts, and this is a study by St. Christopher in Philadelphia, where they have a very active PDA treatment policy with 30% surgical closure in this cohort. They looked at less than 32 weeks or less than 1,500 gram, but in their cohort, the median age was 25 plus 6 weeks at birth. And out of their group, 27% developed late pulmonary hypertension. 31 with early pulmonary hypertension eventually went on to develop late pulmonary hypertension, so about 63% of these infants, versus 54 with early pulmonary hypertension that were free of BPD-PH later on in this cohort. So clearly the early pulmonary hypertension, even within this group, with adjusted odds ratio was associated with having late pulmonary hypertension. So what could we do if we do detect these patients with early signs of pulmonary hypertension? And what could be future trials or future studies? We have here Dr. Thibault, This is a great study looking at the use of sildenafil. First of all, looking at in vitro, they found that sildenafil increased endothelial capillary network formation in human pulmonary endothelial cells exposed to hyperoxia. But they then took a rat pups model where they randomly exposed them to birth to normoxia, hyperoxia with the BPD model, and hyperoxia plus sildenafil. And what they found is that in the hyperoxia group, there's obviously decreased capillary density and signs of pulmonary hypertension, both on echo for functional by the pulmonary acceleration time, as well as signs of RV hypertrophy. And when they had the group exposed to sildenafil early on, they found preserved alveolar growth and lung angiogenesis, as well as decreased pulmonary vascular resistance, RV hypertrophy, and medial wall thickness. We also know that there's, great promises about mesenchymal stem cell, which might eventually help us modulate inflammatory changes and repair mechanisms, which may also be a future avenue to prevent the development of the phenotype of pulmonary hypertension. One study that's been done, which was a pilot trial, randomized premature babies to sildenafil versus placebo times 1 week. The primary outcome was actually BPD, and they found no side effects, but also no effects on BPD. So that's at least a feasibility study that was done, which showed that there's actually no side effect of sildenafil. And so the question would be, if we're able to pinpoint a good profile to predict those that will develop bronchopulmonary dysplasia-associated pulmonary hypertension, then eventually we may have a few avenues to investigate as a potential therapy to prevent. The other question is, what is the role of some of these shunts? And so it seems logical that prolonged alto shunting may accelerate pulmonary vascular remodeling in immature infants during the critical phase of pulmonary vascular or cardiac growth. We know that it's a prolonged exposure to increase systolic and diastolic flow, but also prolonged exposure to systolic and diastolic systemic pressure in the immature capillary bed. And so there's also the controversy that NSAIDs may have anti-angiogenic properties, and that steroids, which may modulate inflammation, may also halt the growth and lead to cardiovascular changes. So this is one study looking at the use of NSAIDs with daily treatments of ibuprofen injected in neonatal rat pups, and found that there was reduced pulmonary vascular vessel density in the developed lung. And in vitro, it seems that ibuprofen inhibits angiogenesis. So already, there's a red flag that NSAIDs may be contributing to some of the degree of pulmonary vascular remodeling in some of these patients. There's also the Benedictus trial that's been done that was a non-inferiority of expectant management for infants with a PD above 1.5 millimeters in less than 28 weeks in the first 72 hours of life. They randomized 265 infants, and they found that expectant management had, first of all, was non-inferior, but was also having lower odds of death for BPD, mostly driven by lower BPD odds. And so we know that BPD is generally associated with the risk of pulmonary vascular disease, and being hand in hand, although there are some patients that can develop pulmonary hypertension despite the relatively benign pulmonary phenotype, driving down BPD and its severity should impact pulmonary hypertension rates and their severity as well. Now, this other study from this group was an observational study in extremely low birth weight infants. And what they did is they looked back at the data related to cath closure of the ductus in extreme premature babies. And they found that dividing them by group or age at which they got their cath closure, those who had a cath closure being done more than 8 weeks, after 8 weeks of exposure to the PDA, had higher pulmonary vascular resistances. And so the question is, well, could there be a subset of patients in which the PDA may be associated with early onset pulmonary vascular disease due to pulmonary vascular remodeling? So the group from Alabama did a retrospective study of infants between 22 and 29 weeks. And what they found is that they do early screen, with screening starting at postnatal day 28, if you're still on the respirator or oxygen. And they had a cohort of close to 400 infants, with 23% of them developing bronchopulmonary dysplasia-associated pulmonary hypertension. And what they found is that the PD exposure duration or the duration to exposure to moderate to large PDA was directly associated with the probability of developing DEF or BPD-associated pulmonary hypertension. But, it is important to be aware that within their cohort, they had active pharmacological treatment for the PDA despite this, as well as treatments using steroids. And so this is not a cohort free of exposure of treatment to ductus arteriosus. The group from UCSF also published their own experience, and they describe a cohort of 256 infants, out of which 22 developed bronchopulmonary dysplasia-associated pulmonary hypertension. And what they found is that there was no association between increasing duration of exposure to moderate to large ductus and BPD-associated pulmonary vascular disease. Recently, we were also interested, knowing that we have a very strict conservative policy regarding PDA management at the Montreal Children's Hospital. And we decided to partner with another institution, the one of Dr. Hébert, where they have a targeted treatment management to actually compare our rates of BPD pulmonary hypertension. So Center A is a center with the conservative policy. Center B is the center with a targeted interventional policy regarding the ductus. And, the first thing I want you to pay attention is that, there is some differences in terms of the rate of death for BPD within the two cohorts, with a lower rate of death for BPD within the conservative policy center population. And so within the study, we only evaluated infants who survived and who had a formal diagnosis of BPD, because the policies within the two centers were that formally these patients would get a screening echo. So as you can see, the patient population within the conservative center was slightly younger, of lower birth weight. You can see that there's almost no PDA treatment, so 7% compared to 81%, but a much higher degree of postnatal steroid exposure. There was much lower level of home oxygen use compared to the targeted treatment population. But when we looked at the outcome of pH or pH more than 2/3 systemic, there was no difference between the two populations. The other thing is that the rate of having an open ductus at 36, 37 weeks was the same within the two populations, which made us wonder if there could have been more or other intrinsic elements which could have contributed to ductal closure, such as the exposure to postnatal steroids. We obviously reran logistic regression models where we looked at institutional policy or PD treatment within the two centers, and we found that there was no association with the outcome of bronchopulmonary dysplasia pulmonary hypertension, although we did find that the group exposed to conservative policy might have had slightly higher eccentricity index on their echo level. As you can see here, 1.12 versus 1.06, it reached significance. The same was true for the subgroup less than 26 weeks. And as I mentioned, having the same rate of PDA, wonder if there's other driving factors such as postnatal steroids. There's been a recent prospective study that described that dexamethasone can contribute to ductal constriction. And so our conclusion was that, a conservative approach seems safe regarding the potential influence of the ductus on pulmonary vasculature. But more studies should look within the RCT level at the outcome of BPD pH. And we had similar results in the UCSF report. So the question here becomes, well, what is the role, contribution of possibly the left-sided elements? We know that there's reports of late complication like pulmonary vein stenosis, but could there be some early contributor that may end up participating to the phenotype of pulmonary hypertension, such as left-sided disease, systolic or diastolic? This makes sense physiologically because of the coronary steal, the inflammation, the adverse postnatal growth, the steroid exposure, but also due to adverse systemic vascular profile from acute kidney injury, kidney immaturity, and vascular stiffness, as well as early exposure to high systemic vascular resistance compared to fetal life. And we know from the adult studies that our babies born preterm have some LV alterations. This was confirmed from the group of Adam Lewandowski, as well as we confirmed it in our cohort of the HAPPY cohort of Dr. Nui from St. Justin Hospital, where we reviewed the echo and found that they have slightly lower stroke volumes, as well as altered systolic and diastolic velocities. So recently we look at a population of infants less than 29 weeks at the Montreal Children's Hospital, and we looked at their echo at 36 weeks. We decided to divide our cohort less than 26 weeks versus 26 to 29 weeks, and we decided to look at their LV dimensions and function. First of all, at the echo of 36 weeks, these two groups had the same weight, postmenstrual age at the echo, rate of pulmonary hypertension, PDA presence, size of PDA, and rate of retrograde aortic flow in the descending aorta within those that have a PDA. We then look at some of the LV metrics, and what we found was that those that were born at the most immature stage, less than 26 weeks, had smaller left ventricular and diastolic volume, smaller LV length, and this was true even after adjustment for steroid exposure and retrograde flow, as well as weight at the time of the echo. And we found that there was an age effect. So if you were born less than 24 weeks, 25 weeks, 26 weeks, 27 weeks, 28 weeks, you had signs of progressively decreasing LV and diastolic volume. And this was true for the areas in systole, in diastole and diastolic volume, the length of the LV, as well as also signs of smaller left atriums at 36 weeks gestational age. And so between the group that's more than 26 weeks and less than 26 weeks, we found a relative difference of end diastolic volume of 11%. Already at 36 weeks. So these alterations that we see in the LV phenotype seems to be gestational age driven, which we know that younger gestational ages are also more at risk of pulmonary hypertension. I want to finish with the story of Massimo, which was born at 24 weeks with severe BPD. This patient had CPAP at 36 weeks on 23% oxygen, so considered kind of severe, depending on which definition you use. And he participated to a prospective natural history project that I'm running at the Montreal Children. And this is his echo. He was found to have suppressed systemic pulmonary pressure on his research echo, which is the Nordic PREM study, so neonatal outcomes related to the early discovery of impaired cardiac function. He was relatively asymptomatic. He looked asymptomatic. So this is sneaky disease. He went to the cath lab almost arrested. He was 1 year on treprostinil and sildenafil. Today he's off all medication. He's being followed in the echo lab and he has a normal development. I want to thank his family to share his story, but I think what outlines for me the story, and a whole interview is available on my website if you're interested, is that they participated in a research project. They were interested. Their kid was relatively asymptomatic. And then boom, we discover pulmonary hypertension. So this is the upcoming project. We have currently recruited 483 patients since November 2019. We're doing an early echo and eventually an echo at 35 to 37 weeks and 39 to 44. It's an echo across all the centers in Quebec, where we're looking at all the time points and also collecting echo clinical characteristics and ventilation parameters. We're collecting 3D echoes, both for the left ventricle as well as for the right ventricle. And this is just for a patient at 7 days who is 700 gram. And so we're hopeful that some of these new metrics may help us better discriminate who of these patients will eventually later on develop outcomes such as pulmonary hypertension. So in conclusion, BPDPH is a silent killer. Detection at 36 weeks post-menstrual age is important, but might be already too late. So the future studies should look at if early signs of PH could be detected in those eventually at risk of developing later PH. I think we have some avenues today as to how to identify them, of who is at higher risk. and that these early echo signs may allow to eventually refine detection of these at-risk infants so that we can enroll them on future clinical trials to try to prevent this phenotype. More studies are obviously needed with the aim to modulate the pH outcome in these vulnerable populations. And what we need to remember today is that other factors, such as potentially LV contribution, needs to be investigated, potentially opening avenues for other mechanistic pathways to be addressed. You can scan this QR code. It will bring you to my website. You'll see some resources there on pulmonary hypertension. And I really want to thank the organizing committee for allowing me to present today. It's really a pleasure and honor. Thank you so much.